Bismillah ar-Rahman ar-Rahim. Today we'll do like a final revision about the important exam question. First of all, as I always start, I will start with the operative vaginal delivery. The first exam question, once you diagnose shoulder dystocia, or what is the definition of shoulder dystocia? Any maneuver to deliver the shoulder after delivery of the head, and the old definition is delivery of the head and 60 seconds until delivery of, or delayed delivery of the shoulder 60 seconds after delivery of the head. Once you diagnose shoulder dystocia, the head will be retracted to the woman pelvis. You should call for help. The first exam question. Push the buzzer button, call for help, call for assistance. This is the first exam question. For whom you need senior, junior anesthesia and neonatology. So midwife, additional midwife, experience, obstetrician, seniors, neonatology, and anesthesia. And the first safety point after calling for help is stop what you are doing. If there is pushing, stop pushing. There is oxytocin, stop oxytocin. Put the woman flat and bring her to the edge of the bed. The second exam question. The third exam question is what will be the successful maneuver, which is macropart plus suprapubic, and the success rate is about 90%. So macropart, which is size to abdomen or knees to ears, or excessive flexion with abduction to widening the pelvic diameter, straightening the lumbosacral angle and widening the pelvic diameter. Macropart plus suprapubic pressure, either routine or axial. Routine or either continuous or rocking. Suprapubic pressure means towards the pelvis on the anterior shoulder to make it smaller in size to be under the symphysis pubis. It has a very important safety point, which should be from the side of fetal back. So the baby looking here, I will do the pressure from here to make the shoulder smaller. If I did the pressure from here, I will expand the shoulder, so the woman will not deliver. With axial traction means in the same axis of the baby, not upward, not downwards. All these are safety points and a lot of important points to consider. Suprapubic pressure, continuous or rocking from the side of fetal back to reduce the pisiacular diameter or the piacular diameter or the shoulder diameter. Routine and axial traction. Routine means not excessive. Axial means straight away. This is the head and this is the shoulder on the axis of the baby, not upward or downwards. And routine, not excessive traction. So what you are usually doing, not put a lot of burden on the baby head and shoulder and necks, because you will do a brachial plexus injury. Episiotomy is not a must. It only will help you to rotate, make your life easier, the internal maneuver easier. Consider episiotomy if it will make the internal maneuver easier. What is the internal maneuver? We said it's 3 techniques. Push from here to rotate the baby, here to help you, or remove your hand and put it to rotate in the other direction. So open, woods and screw, or reverse wood and screw. So if this is the shoulder and this is the head, I will rotate the baby in that direction. One finger here and one finger here. I will slide my hand into the back of the anterior shoulder and rotate the baby. This will be the first maneuver. One finger here, two finger here, one front, one on the back, and one on the front of the back shoulder. This is roping 2. Reverse wooden screw, which I will remove this and put this one here to rotate the baby in the other direction. These are the 3 maneuvers to deliver the baby head. Again, shoulders and head. One finger here. My right hand, slide it behind the anterior shoulder. Behind the anterior shoulder to rotate the baby. Not rotating. Your left hand in front of the posterior shoulder, helping the other hand to rotate the baby. Not remove this one and put this one here. Rotate the baby into the other oblique diameter. Failed. deliver the posterior arm. So this is the internal maneuver. Deliver the posterior arm. Try either of maneuver, depends on the operator, but the RSOG recommends to do the internal maneuver first because the posterior arm have an incidence of fracture clavicle. Okay, so internal maneuver first, then posterior arm. Failed, inform senior. Inform consultant, obstetrician, and anesthesia. If all maneuver fail to release the impacted shoulder, you will put the woman on the all four. If appropriate, means there is no epidural. If there is epidural, the answer will be repeat again. I will omit this one. That's why he put here, if appropriate. The all four was woman epidural, how you will put her? She cannot move. Fine. So epidural is not appropriate to be, or a woman with all four, or this position is not appropriate for woman with epidural. So I will repeat, omit this one, and I will repeat the macro part and the suprapubic. And then the internal, then the posterior. If a woman have epidural, I will remove the all four. Then I will repeat. Failed the destructive technique or the third line maneuver, which is fracture of the clavicle, cleidotomy, fracture of the symphysis, open the pelvis, symphysiotomy, or the Finelli maneuver, which is put the head back and do cesarean section. This is the important point of shoulder dystocia. Macro part means excessive. You see, remove the pillow, put the woman flat, bring her to the edge of the bed, axial traction, not upward, not downward, suprapubic pressure from the side of fetal pack. This is to deliver the posterior arm, and this is the macro part. Both together, 90%. The all four, 83. To remember what you will do, actually, I don't like this, prepare or assistance. This is the RSOG abbreviation. Leg for maneuver, episiotomy, suprapubic, internal, reverse foot screw, tries the posterior arm. This is you see, this is the step to answer in the exam. It's pale sister, a mnemonic to remember. But I would like this. Helper technique. Call for help, evaluate, legs, pressure, suprapubic, legs mean macropal. Enter, rotation, remove the posterior arm and rule the patient. Hands, all four. The helper technique. Summarize all the points. Call for help, evaluate and explain and do episiotomy if needed. Legs, excessive flexion and abduction. Remove this pillow and put the woman flat and bring her to the edge of the bed. You see, this is the axial traction. Not excessive force, axial traction. Not upward, not downwards. And this is the suprapubic pressure in the direction of the pelvis. And it should be from here, from the back. The baby is looking here. So from the back to reduce the diameter of the shoulder. After that, the internal rotation. Episiotomy, internal rotation. 1, rotate the baby here. 2, your left hand in front of the posterior shoulder to help the other one to rotate. Failed, remove and put this one in the back. The right hand in the back of the posterior shoulder to rotate the baby in the other direction. Deliver of the posterior arm which have a risk for fracture humerus. The Finelli, symphysiotomy, or cleidotomy is the destructive technique. This is the first technique. Open 2. The second technique, this is the first technique also. Your right hand slide until to the back of the anterior shoulder to rotate the baby anti-clockwise. Failed, your left hand will be here in the front of the posterior shoulder, helping rotating the baby anti-clockwise. Failed, I will remove this and put my right hand here to rotate the baby clockwise in the other direction. These are the 3 internal rotation which comes in the exam. Woods and screw and reverse woods and screw in the other direction. Every maneuver for 30 seconds. Delivery of the posterior arm which have a risk about 12 or 2 to 12 fracture of humerus. Every day until now, the exam is tomorrow, and still I have question about the operative vaginal delivery, how to answer in the exam question, how to do, what to do, when to do. I know it is a little bit difficult, but it's a practice. You should know all about the operative vaginal, when to, how to assess, and we spend a lot of question doing the operative vaginal delivery. The first assessment, the head at the spine or low. Above this, minus, there is no operative vaginal delivery. So 0, +1, +2, mid-cavitary, low, more than +2, on the perineum, on the pelvic floor, distending the vulva, outlet. Outlet means wriggly, which is not rotatory. Okay? Outlet means wriggly forceps or ventouse. Mid-cavitary, either to be rotatory or non-rotatory. Non-rotatory if the occiput is here. This is the occiput, anteroposterior. The occiput is here. Sensoput is here and the occiput is here. So if the head like this is the occiput, the triangle of the occiput, and this is the rectangle of the sensor, and this is the sagittal diameter. This is in the middle way, in the anteroposterior diameter. So non-rotatory forceps, which is the navel part, up to 45 degree non-rotatory forceps. But transverse or posterior, occipito-posterior, or occipito-transverse, left occipito, all this more than 45 degree, it is rotatory. I need rotatory. Rotatory keel and rotatory ventouse, manual rotation. According to any rotatory will be in the theater, except it is well below the ischial spine. Easy rotation in para 1. So it will be in the room. So what will be the chances to fail? As we said, big mother, big baby, high PMI, the woman is it is a higher mid-cavitary in the pelvis, or there is feature of CBD +3 caput or +2 caput. So I will not do it in the room at all. So either low, antero, occipito anterior, or easy rotation, this will be, I think, in the room. Even it is occipito anterior mid-cavitary in multiparous woman, all this for a senior can do a forceps, navel palm forceps, a straightforward forceps can be in the room. Otherwise, will be in the theater. So the assessment, the criteria, 1/5, usually nothing per abdomen. So the head mostly engaged. I will feel nothing per abdomen. Fully dilated, rupture of membrane, can do the position, a proper anesthesia, either local, look, or epidural. And follow the criteria, the A, B, C, D, E, F, G for the approach. A, address the mother, adequate analgesia, ask for help if needed, and take consent. B, for the bladder, evacuate the bladder. C, for the cervix and the contraction. D, for expecting shoulder dystocia, episiotomy, apply the forceps. Is it matches together or no? How to do the apply. Gentle, G, for gentle traction, 3 words only until the jaw, 3 pulls only until the jaw appears, then stop the traction. 3 pulls only, no progression, no descent, stop. Even after 1 pull, no progression, call your senior. 1 pop off, call your senior. 2 pop off, no more. This is failed ventouse. 2 pop off means almost it will be a cesarean section, because sequential forceps have a higher risk of obstetric trauma and intracranial hemorrhage. So the assessment will depend on the criteria. Below the ischial spine, occipito anterior, occipito posterior. Any high risk to failure will be in the theater, except if it is low, easy rotation. Low, occipito anterior, no rotation, or easy rotation. Or a favorable condition, like occipito anterior in a multiparous woman, cannot push. So this can be in the room. Does this make sense? Clear? So outlet low and mid already we discussed, and the rotation already we discussed. Non-rotatory in the middle line, the sagittal suture in the middle line, or less than 45 degrees. Rotatory more than this. What are the options of rotation? either manual rotation with occipital-anterior forceps, the navel parts, or ventouse, digital rotation, or forceps, healant. The outlet from down, the fetal scalp visible without separating the vulva. The skull on the perineum, non-rotatory. It's already outside. 0 plus 1 mid-cavital, plus 2 or more not in the pelvic floor, low. Rotatory or not rotatory in the middle line or no. These are the 3 forceps. Navel parts, wriggly, the outlet, navel parts, and healant, the rotatory forceps. It has a sliding look so it can correct asynclitism. If the head is not directly engaged or the sightal suture is deviated to one side, I can advance one plate and retract one plate, so I can correct parietal presentation or asynclitism. Not an ear, I will correct. Ear coming means obstructed in preterm. Okay. Again, these are the types of forceps. Rotation, already we discussed the types of rotation: digital rotation, manual rotation, kiwi, easy rotation, delivery by direct occipital-posterior, no rotation, Keeland, and which is the most difficult. Rotational deliveries are more complicated, should be in the theater because it's more likely to fail unless it is well below the ischial spine. Consider performing in the theater, it is an outlet delivery. Consider performing delivery in the theater unless it is an outlet delivery. This is when he said in the RSOG, if you remember, in the MOOC, the head is well below occipital-posterior, so easy rotation. And it is mentioned in the chart as well. Okay, here, this is the indication: fetal compromise, maternal delay. If you remember, 1, 2, 3. I will put here multigravida, and I will put here primigravida, and I will put here with epidural, without epidural, with epidural, without epidural, with epidural, multigravida 2 hours, without epidural 1 hour, primigravida with epidural 3 hours, without epidural 2 hours. So this is the rule of 1, 2, 3 to remember the descent or the delay in the second stage. Multigravida 1 hour enough without epidural. Have epidural only 2 hours, 1 hour passive and 1 hour active. Primigravida without epidural 2 hours, then interfere, maternal delay. 1 hour passive and 1 hour active. Epidural, I will add 1 hour in the passive, so 2 hour passive plus 1 hour pushing. Primigravida for 3 hours. Okay. And usually the indication will be maternal delay and fetal compromise. This is the assessment, either to do it abdominal, vaginal, and prepare the woman, or to do the APC approach. This is the comparison between the vacuum and the forceps. The vacuum, the ventouse, more likely to fail, more likely to be associated with cephal hematoma and retinal hemorrhage, more likely the woman will be worried about the baby, all of them above 2, the odds ratio more than 2. Less likely to be associated with perineal trauma, yes, 4 with forceps almost 10, 8 to 12, almost 10 with forceps. No more likely associated because with cesarean section, because I will not put ventouse unless it is an easy delivery. No more likely to be associated with low Apgar score or need a phototherapy. Okay. You see here, continue in the room if the head is low, outlet, so low forceps or outlet forceps. No rotation means occipital anterior. So if it is low, +2, +3, or outlet on the vulva, occipital anterior, or even occipital posterior, rotate easily, well below, multipara, and no feature of CBT. So this is the criteria to go to the room. So the indication, as I told you, I will ask myself 3 questions. Do I need indication to interfere? When I will interfere? And what to do, which instrument, and where? In the room or in the theater? So why I will interfere because there is delay, maternal delay, fetal compromise, or combination. This is the indication. When 1, 2, 3, the timing. Where? In the room or in the theater. Occipital anterior or well below the ischial spine. Occipital posterior low at +2, +3, easy rotation in multiplus woman, and no feature of CBD. So this is how to choose when and what. Forceps or ventouse, it's your choice, operator choice. Are you competent in doing forceps? Do forceps. It's not likely a good failure. Forceps means delivery or fail. Ventouse can pop up, cannot deliver, more likely to fail. So if you are competent on forceps, go to forceps. In the theater, if there is 1/5 palpable, high head at the spine, mid-cavital, okay, both are the same. Rotation required, most probably, if it is occipital-posterior, I will go to the theater. Occipital-posterior at the spine or +1, I will go to the theater. But +2, 3, it will be easy rotation, change. With suspicious CTG or suspicious CBD means there is +2 caput or molding, so I have that cephalopelvic disproportion. So more likely to fail. Choose of the instrument, what I will do. Is it ventouse or forceps? Usually we are going to forceps because forceps are safer even in the preterm. Ventouse will not be before 36 because consider with caution. It's not safe after 36, only safe. So 32, it is obsolete. 32 to 36, which is this 4 weeks, use with caution. Why? I will not use, I will use forceps. After 36, ventouse. The application, if you are not sure about the application, don't put it. If you don't know the flexion point, don't put it. If you are not sure about the position, don't put any operative vaginal delivery, go for cesarean section. Attempts of the rotation, only 3 pulls with the forceps, no progress, no descent, no more. With ventouse, 3 pulls. If the head is low or in the perineum or near below to deliver, you can pull another. 1 pop off, call your senior. 2 pop off, usually it will be a CS. Or a senior decision to put sequential forceps or go to CS, usually it will be a CS because of the destructive approach of sequential ventouse and forceps. How many attempts for rotation? If you cannot rotate easily, don't rotate at all. Either rotation easily, the forceps lock easily and rotate easily, otherwise don't rotate. And the traction, as we said, it's only 3 pulls. After 3 pulls, no more. For ventouse only, for vacuum, if the head at the pelvic floor, I can pull another 3. Failed ventouse, forceps, or cesarean section, this is a senior decision. If I am competent to deliver, I will assess the situation. No CS. No need to do heroic action. Okay? It's not, you will get a Nishan if you deliver here by forceps vagina. Excessive traction can cause a lot of trauma for the mother and a lot of trauma for the baby. Second stage is a little bit challenging, but safer than what you will do. You will have a shoulder dystocia, you will have a fetal distress, and you may end by the baby in the NICU and the destructive mother. So either easy rotation, easy forceps, or cesarean section. No need to do excessive force. Okay? Are we happy until now? Any question about?
Hello, you call me? بروسين يلا.
تقوى في الليبر وورد. Okay, God bless you and your hands, Tago. Any question? Happy to continue? Okay, Aman, you have a question? I muted Tagwa because she's happy to continue. Clear. Okay. Shanza, do you have a question? Am I
Sir,
correct?
I wanted to ask you, you told about breach because I joined late, breach
About what,
deliveries,
my dear?
that we will not apply the same criteria for the breach. In what
No,
condition we can do forceps, when is, if less than 37, then we will do C-section.
for the breech, you are thinking about amniotomy or no, the delay, cesarean section. The breech is not engaged. There is no forceps in the breech. The breech will be on the aftercoming head. If you need a forceps for the breech, it will be in the aftercoming head. There is delivery interval. There is a new talk about the breech. They added, I think it was 3 minutes, 5 minutes. They make another one 7.5 minutes delivery. If you remember in the breech session, we said from buttock to head 5 minutes,
Yes.
from umbilicus to head 3 minutes. They
Yes.
add another time 6.5 minutes.
And sir, overall is 30 minutes, na?
For the delivery of breech.
Yani after 30 minutes, we will interfere.
No, if there is twins, you are speaking 30 minutes for the twins. The breech is the same. The breech is a delivery, so you will follow the partogram. The breech is a delivery, so you will follow the partogram. 1, 2, 3 in the second stage, and every 4 hours, 2 centimeters in 4 hours in the first stage. You are speaking about the twins. The 30 minutes
Yes,
for the twins.
yes, sir. I got confused.
Yeah, no problem, my dear. You are welcome. So the fetal distress or the reduced fetal movement is nothing. The first episode auscultation, the second episode ultrasound. If you have no fetal heart, ultrasound to exclude fetal death. This is the summary of this chart. Okay. My second big issue, I feel that it will come in the exam because all the trust now is following the new protocol. Why? Because the old protocol is little bit old. So the screening is going to be changed. I think the RSOG also as well will change it. Most of the trusts now following the local protocol of the NHS. This one. You see here, the intrauterine small for gestational age. You see here, 2013, 2012, 2011. They are changing. Even they posted yesterday a new about the recurrent miscarriage, a new GTG about the recurrent miscarriage, because the last one was it was 2011. Even I didn't read it. I will try to read it tomorrow after we finish the record to see if there is any changes or no. I think it will be a lot of changes because the previous one was very deficient. My concern is that this will appear in the exam again, because most of the trust following the NHS protocol, which provoked by Leeds University. This is the NHS protocol. So let's see the trust or the RSOG protocol, and after that we'll discuss again the NHS protocol between the RSOG and the Leeds University. The SGA usually assisted at booking at 20 weeks and in the third trimester. Reassess in the third trimester. 3 steps to remember. At booking, I will score risk factor. 3 minors means uterine artery Doppler. Why uterine artery Doppler? I will assess the blood supply to the uterus. Is it normal? I will repeat assessment in the third trimester. Why? Because the woman has 3 risk factors for small for gestational age. Abnormal, I will go for serial ultrasound assessment from 28 weeks. Most of the trust do it from 28 weeks, not from 26. Doppler only, uterine artery Doppler from 20 to 24 weeks. One measure, I will go directly for the serial assessment. There is fibroid or high BMI. I will not assess by the semifundal height because the semifundal height will be inappropriate. So I need what? Serial assessment of the fetal size, because the estimation will be wrong. The fibroid will give you a bigger gestation, and the high BMI always giving you a higher presentation or a higher semifundal height, higher than usual or higher than expected. So if the woman is obese, more than 35, or have a large fibroid or multiple fibroid, also it is embedded here. One fibroid more than 5 centimeters or multiple fibroid. It's not written here. Large fibroid more than 5 centimeters or multiple fibroid. Both of them will affect the semifundal height. So I need serial gross scan, weight from 28. Before 16 weeks, if you have previous hypertension, if you have any risk factor diabetes, any risk factor for renal impairment, antiphospholipid, for any risk factor for preeclampsia, I will give aspirin at 12 weeks. What I will forget, the low papa. The low papa is a hint for small for gestational age. If it is more than 0.5, this will be considered as a major risk factor. So I will put the patient here. Low papa is considered as major, not a minor. Fetal echogenic bowel considered as major at the time of the anomaly scan. This will be at the booking. If I found the booking blood at 12 weeks done gives you low papa, so I will escalate or I will put the woman on the gross scan from 28 weeks. So this will have a serial scan at 28, 36. It will be booked once. Once I put the woman on the scale of the gross scan, it will have 4 letters, 28, 32, 36, like this, every 3 to 4 weeks. Usually, it will be 3 weeks difference. So I can get a difference in the weight. This is called, I will put the woman on the gross scan scale. You will have 3 appointments directly. And I will put the baby, plot the baby on the gross chart, the 10th centile and 19th centile. This normal babies will grow here. 10% of baby here, 90% of babies here. Normal babies will be here. More than 95th, this is large for gestational age, means induction of labor at term, 39. Less than this means small for gestational age, also induction of labor targeted now at 39, 38 to 39. Not before this, except there is abnormal Doppler. So this is the summary. Serial assessment, I will put it from here. Once I have a risk factor, I will put a serial gross scan from 28 weeks, every 3 weeks. Okay. Uterine artery Doppler have a moderate prediction for preeclampsia. As I told you, if a woman have preeclampsia or have diabetes, and I am controlling her diabetes, the baby will be like this, reduced gross velocity. Is this a preeclampsia or diabetes? Placental insufficiency? The uterine artery Doppler will tell you. So uterine artery Doppler is helpful to moderate prediction for preeclampsia. And small for gestational age as well. Preeclampsia in the first trimester and small for gestational age in the second trimester. Okay. What will be the surveillance? The umbilical artery Doppler. The systolic, the diastolic. The end diastolic flow or velocity. Is there blood at the end of the diastole or no? Normal every 2 weeks. Abnormal fetal weight every week and Doppler twice a week. Absent or reversed, so fetal weight weekly and Doppler daily. If it is severe preterm like 28, I will do it by ductus venosus Doppler. This is the surveillance. First of all, I have a screening tool and surveillance tool. These are screening at the level of the midwife, semifundal height, measure from the symphysis pubis to the height of the fundus. Accurate, the woman will be with the midwife. Gestational age, semifundal height. Every visit she will have a measure. It's the baby is growing fine. She will be in the midwife. She will not be referred to the obstetric care unit. Otherwise, on history, previous small for gestational age or preeclampsia, history based or biochemistry, low papa or uterine artery Doppler. All these are screening by measurement at the midwife or screening by chemicals or history. This is a screening and this is screening. From here, I will start the treatment. I need to confirm by ultrasound the fetal gross the abdominal circumference less than 10% of baby, less than the 10th centile, this is confirmed IGR, the surveillance will be uterine artery Doppler. So always remember that there is a step check here. Weight, the baby weight, abdominal circumference, or estimated fetal body weight came on the 10th centile or below. This is 10th and this is 19th. The baby came here, means it is confirmed small for gestational. The next step will be uterine artery Doppler, normal every 2 weeks and end the delivery after 37. Reduced, but still the end diastolic volume or velocity or flow is present. Weekly and twice weekly Doppler, umbilical artery Doppler. Absent fetal medicine. Why? They will do ductus venosus Doppler daily, umbilical artery Doppler daily until 30 to 32 weeks. And I will consider delivery here, offer delivery here. Once I have absent or reversed, there is no chances to do induction of labor. Here I have chances to do induction of labor with low threshold for cesarean section. Any change, I will go for cesarean section. Here, cesarean section. And the follow-up will be ductus venosus Doppler until 30 weeks. Consider. Terminate at 32 weeks by cesarean section. When I will go for cesarean section means I need steroids. And for sure, neuroprotection. If it is 32, I need magnesium sulfate as well. If I will go for delivery, admit the patient, steroid, magnesium sulfate, and deliver here. Logic approach. Persistent static growth after 34, give her steroid and deliver her. So consider delivery more than 34. If the baby is not growing, even there is a reduced, not absent, reduced pulsatility index or resistant index, more than 95th. To standard deviation. So in the extreme, extremely reduced, but still present. The change happened where? The woman low risk, no follow-up if the baby weight is normal. You see here, low risk means in the midwife, SIMC fundal height. No risk factor, she will keep measure the SIMC fundal height by her midwife. There is risk factor, the baby is above the 10th centile, you see, this is called what? What is this called? Gross scan. Every 4 weeks, because only there is a risk factor. The age, drug abuse, previous GSA, small for SGA. So the baby came more than 10th, not than 10th. More than 10th is not small for gestational age, confirmed. But because of she have a risk factors, it can be plotted on the gross chart. The gross chart by follow-up of a gross scan, but from 32 weeks, not from 28. From 28, if it have abnormal Doppler and the baby weight is reduced. So I have a lot of risk factors. High risk, diabetes with vasculopathy, SLE, congenital heart disease, previous SGA, hypertension, previous SGA and still birth, low papa, less than the 10th centile, echogenic bowel, significant bleeding, or the fetal weight less than the 10th centile, I will do what? Aspirin if needed, and I will do uterine artery Doppler. Here, they highlight the importance of uterine artery Doppler. If it is normal, gross scan, 32 weeks. Abnormal, the gross scan will be, the serial ultrasound will be from 28 weeks. Every 2 to 4 weeks. Usually it will be every 3 weeks until delivery. And my aim is 38 to 39, unless I have a problem here. The baby is not growing and the uterine artery Doppler is abnormal, so I will refer to the fetal medicine to do the ductus venosus Doppler and daily Doppler. Until 30 weeks, I will consider 32, I will deliver. If you remember the changes, how to modify the answer. Why they did this? Actually, the start is late, not 26 to 28. So it is all about money. The fetal medicine is very busy by the gross scan and the Doppler studies. So they tried to reduce the number of referral to the fetal medicine. And I am facing this trouble. Every time I'm trying to book, I will write here, it is indicated according to the RCOG guidelines, they will refuse the case and they will say, we don't have capacity unless it's follow this. That's why I'm telling you the exam will come from here, because this is the actual practice in the UK now. And this is how they are giving the UK candidate marks above the overseas. And we will try to reduce this as well. A lot of mentors now working in the NHS, and they know that these tricks are not anymore guaranteed for the overseas or the UK candidate. So we need to do this, the same practice. My concern here is that they consider now the BMI 40 as score 2 in the antenatal as well. And this is wrong. It's not written at all in the guideline. The RCOG said after delivery, the patient will be dehydrated, less ampulated, so the PMI will be scored here, 2 or 1. Actually, in my trust, they consider this in the antenatal. If it is 40, they will give her a score 2 antenatal in the clinic. I tried to speak about this, but they are shut down. No, it is not. It is not like this. So the antenatal score 1 until now, according to the RCOG, and I will do this if I'm going to the exam. Antenatal, the patient is ampulated and hydrated, unless it is extremely high, more than 50 or that, I will be a little bit risky. If a woman have previous, any question about the VTE? I think I speak about the VTE a lot. Any question about the VTE? I want to finish most of the topics today, so you can have a lot of time to discuss.
Sir, can you just tell us about the special conditions with history and without history?
The history of DVT, if it is provoked or not provoked. Provoked means related to major surgery. Provoked related to major surgery, so the score will be history. Unprovoked means related to pregnancy or estrogen, the score will be 4, and all this is prophylactic dose. Because you posted a question on the DVT, is it a prophylactic or is it a high dose? Antiphospholipid scores 1 alone, but if you have a previous DVT with thrombophilia, no, this is high risk. So antiphospholipid alone, it's low risk, score 1. Okay.
And the factor V Leiden deficiency?
Is it heterogeneous or homogeneous?
If heterogeneous,
Heterogeneous,
then we will
1.
1, and if homogeneous, then
Homogeneous,
we will
high
take
risk thrombophilia, so I will consider 3 antenatal from 28 weeks and 6 weeks postnatal.
But if heterogeneous with family history, then it will change.
It's 6 weeks low risk thrombophilia plus 6 weeks postnatal. So antenatal score 2. Now you know the tricks. Low risk thrombophilia alone score 1, which is the heterogeneous factor V. Family history of DVT score 1. This is antenatal. Ampulation and hydration, no need. But postnatal high risk 6 weeks, because this will put her at a highest risk in the postnatal. 6 weeks. Exam question. RCOG trick. This is an RCOG trick to know, are you aware or no? Family history alone, and it should be in the first degree, not her cousin, her brother, her sister, her mother. Family history of DVT, family history of unprovoked estrogen-related or in pregnancy in the first degree. So her sister, her mother, not her aunt, not her uncle, not her any cousin. And low-risk thrombophilia, as you said, like heterogeneous factor V, not antithrombin. You see, antithrombin is here. High-risk thrombophilia. High-risk thrombophilia is antithrombin. So from 28. Bridging, I will speak about the bridging. So any question here about the chart? I will collect the score if I have 4 antenatal from booking. Antenatal means from booking. Consider antenatal from booking if you have
Sir,
score risk factors.
yes. Sir, you were telling something about mid-cavity and operative delivery. It should be and, not or. You highlighted before.
Yeah. Mid-cavitary or rotational.
Or.
The or is here, not here.
Okay.
Mid-cavitary or rotational, which is the difficult forceps, it will score 1. If it is mid-cavitary, score 1. If it is rotational forceps, score 1. It's typing error only here. It's typing
Yes,
error. Mid-cavitary, rotational, or operative. No, it's here. Mid-cavitary or operative or rotational operative vaginal delivery. Okay?
Yes, sir.
So if it is mid-cavitary, means 0 or +1, or occipital posterior or occipital transverse, operative rotation, this will be a difficult forceps. So need to score 1.
Dr. Hani, regarding the admission is in the antenatal and postnatal.
Yeah, okay. Admission antenatal will be considered during the period of admission, but readmission in the postnatal 10 days. Readmission, moderate risk factor, 10 days. If it is readmitted or prolonged admission, usually if a woman delivered normal, after how many hours she would go home? There's a practice, there's a nice guideline in your hospital trust, Farida.
Depend upon this normal delivery or cesarean.
I love this. It is normal delivery. So it will go directly. It can go directly from the labor ward after 2 hours.
Yeah.
Home. So this will not be considered as admission, but the patient have postpartum hemorrhage. The patient have operative vaginal delivery. The patient have trauma, any trauma. So she will not go home. 24 hours at least. This is the trust protocol. But if the admission is prolonged more than 4 days due to any other thing, the baby is taking antibiotic prophylaxis, it happened in your trust or no? And the woman will stay in the hospital for 5 days because the baby is in an antibiotic protocol for GBS. So this is a prolonged admission. Even it is not for the mother, it is for the baby, but she is restricted mobility. If the patient readmitted due to any other things, appendicitis, torsion, infection, so this will be considered as a moderate risk factors. Alone it will be score 2. Alone, moderate risk factor for 10 days. She have a lot of risk factors, more than 3, or persistent, I will escalate. Escalate means 6 weeks. Why I will give her 1 month? Escalate from 10 days, 6 weeks. Persistent, 4 risk factors, or persistent comorbidity. So 6 weeks. Clear? Any question here in the chart?
Dr. Hani, sorry, suppose I give this any prophylaxis like for ovarian hyperstimulation or antiphospholipid antenatally.
Yeah.
When we will come postnatal, it will not be under this one anywhere requiring
nothing. This is transient. No, this is transient risk factor. Ovarian hyperstimulation in the first trimester. Any other transient risk factor only during the admission. During the admission, this is transient risk factor. Hyperemesis during the admission, infection, low hole travel, all this is transient risk factor. Ovarian hyperstimulation also is transient risk factor up to 12 weeks only.
Okay, thank you, Dr. Hani.
You are welcome.
And Dr. Hani, about the sickle cell disease, now we
I will follow here, not the sickle. I will follow this one.
Okay.
Sickle cell means intermediate risk factors to antenatal and 6 weeks postnatal. Unless he told you the patient is postnatal. Postnatal delivered vaginal, I will give her 6 weeks. I will give her 1 week. Postnatal delivered cesarean section, I will give her, because some of the question may be old. But the VTE,
so Dr. Hani, but it is not like from the 28 and then 6 weeks, and if she is coming in the postnatal, it will be the same for 6 weeks, even normal.
Yeah. I think yes. Once sickle cell escalated, it will be considered as antenatal and 6 weeks postnatal.
Yeah. Okay.
So follow the VTE, not the sickle cells. Any other question? Let's go to the bridging. This is the risk factor and the high dose and the transient risk factor. Already we know about it. The scoring, antenatal and postnatal, which will give 4 and which will give 3. This is how I remember in the exam. 4, a previous VTE not related to surgery, unprovoked, related to pregnancy. So antenatal from booking. You see here? From the first trimester. Once the woman come for me, usually it will come at booking, because you said it is in the viability, or the viability scan, the patient even will come after that. So the booking will be between 10 to 12 weeks, 11 weeks. So antenatal means from the first trimester, from booking. Not from pregnancy test. Score 3 means from 28. Score 2, except for what we have discussed, which is the family history of thrombophilia plus low risk thrombophilia, family history of DVT. If the patient admitted antenatal, consider thromboprophylaxis. Any admission antenatal, she is pregnant, any admission, consider thromboprophylaxis. If prolonged admission more than 3 or readmission in the hospital in the Preterm, consider 10 days. Okay?
Sir, I want to ask you one thing. For score 4, we were giving 50% or 75% of the treatment dose.
No. Score 4 means prophylactic. Prophylactic means half the woman weight.
Yani same we will follow.
Yes, because this is a prophylactic dose. The high dose means DVT plus 1, 2, 3. The only indication. Recurrent DVT, antiphospholipid syndrome, or antithrombin deficiency. These are the indications only to give a high dose. All this prophylactic dose, which is half the woman weight. Okay?
Okay, sir. Okay, sir.
You are welcome. So this is the score and how to deal with the scoring in the exam. My problem is here. This is the high risk of DVT. This is the one which Shanza just asked, which is the high dose. Previous DVT on warfarin, recurrent. Previous DVT with antithrombin. You see? Previous with antithrombin or with antiphospholipid. So these are the 3 indications which I spoke about. Recurrent DVT on warfarin, previous DVT with antiphospholipid, or previous DVT with antithrombin. Here I will escalate a high dose, 50, 75, or total treatment dose from antenatal until 6 weeks postnatal, or from shifting. Here I need the bridging from shifting from warfarin, low molecular weight heparin, then warfarin after delivery. Or if the patient have prosthetic valve, I can continue on warfarin during pregnancy. The high risk from here downwards, this is the chart. You see here, prophylactic, score 4, score 3, prophylactic. He didn't say high dose. This is the chart. The first, this is score 4. The first one is the chart. Recommend antenatal and 6 weeks postnatal, prophylactic, half the woman weight. Asymptomatic, high risk thrombophilia, score 3. Heterogeneous factor V, score 1. Or compound any heterogeneity, this will be considered as a risk factor. 1. Asymptomatic low risk thrombophilia, gene mutation, or factor V, or heterogeneous factor V mutation. Heterogeneous factor V, heterogeneity, this will be considered as the risk factor. Asymptomatic high risk thrombophilia, which is the antithrombin, or homogeneous factor V, this will be score 3. Heterogeneous, score 1. This is what you have mentioned. High risk thrombophilia, score 3 from 28 weeks. Consider antenatal and offer from 28 weeks and 6 weeks postnatal. Homogeneous factor V, score 3. Heterogeneous, 1. Antiphospholipid is not scored here. She is taking low molecular weight because of the recurrent miscarriage. It's a score 1 only. So she is not taking because she is high risk for DVT. Because of the recurrent miscarriage, she is taking aspirin and low molecular weight heparin. So in the VTE score, the antiphospholipid scores 1. So postnatal, she will be only 5 to 7 days, as recommended by the RCOG practice. It's mentioned in the guideline.
Dr. Hani, this one, the last point, the 6 weeks, is it with low risk thrombophilia and the family history? It will combine, will cause 6 weeks here on the
This
right.
one, yeah,
the-
it's mentioned here. This is the RCOG trick, low risk thrombophilia. You see
Yeah.
here, low risk thrombophilia plus family history, it will be high risk in the postpartum.
6 weeks, yeah.
So 6 weeks. This is always, they love this. If other risk factor, like postpartum or 6 weeks, if significant family history. So family history plus heterogeneous or low risk thrombophilia. Okay? So this is the trick of the RCOG. They loved it. He will bring the patient antenatal with heterogeneous factor V, and her mother have a DVT in pregnancy. So family history plus heterogeneity. It will not take antenatal, ambulation only, hydration, but postnatal she will be 6 weeks, not 2, not only 10 days. The indication for high dose, already we speak about it. The bridging. I will make it like a story again. If a woman taking warfarin in pregnancy, I will stop the warfarin at 36 weeks or 2 weeks before elective birth. If she would deliver at 38 or 39, I will deliver at 36. And I will shift the patient on a treatment dose, not a prophylactic dose. When I will start it after 2 days because the warfarin is already high INR. So I will not put the warfarin directly when I will stop. I will not put the low molecular weight heparin directly when I will stop the warfarin. I will start it after 2 days. Then I will keep the patient on low molecular weight heparin treatment dose until delivery. By treatment 24, prophylactic 12. Then I will go by the enhanced recovery program during the cesarean section, like what? Ambulation, hydration, carbohydrate loading for hours, drinking water. If the patient have high PMI, put her in the pneumatic compression, in the theater, hypothermia. As I told you, always you will not consider the hypothermia. There is a blanket to put above the patient in the theater. So even a thermal blanket with a heater. So avoid hypothermia during the surgery because most of the patient will have hypothermia in the surgery. Meticulous hemostasis, avoid drain, avoid morphine, early non-steroidal, early removal of the drain, early removal of catheter, ambulation, hydration. All this is the parts of the enhanced recovery program. After removing of the epidural, 4 to 6 hours, I will start the low molecular weight heparin, prophylactic or treatment according to the woman high risk or no. Then I will continue for 1 week. I cannot start the warfarin unless 1 week postpartum. I will continue pause here. Why? Because the warfarin will need 2 days to start an action. To get again the INR 2 to 3, I will not stop the low molecular weight heparin because the woman will be suddenly dropped. The warfarin does not start it. It will start after tomorrow, and you stop the low molecular weight heparin. So you need to continue pause until you go to the target INR, then stop the low molecular weight heparin and continue with warfarin alone, and she can breastfeed as the patient is already now on the 8th day. My problem also, if he mentioned that the creatinine clearance less than 30, it's always coming in the exam. So involve the renal and half the dose, because the low molecular weight heparin is excreted by kidney, and in the extreme, remember to do the anti-factor 10. If the PMI is high or low and the target is 0.6 to 0.1 before the injection, and I think 1 hour after the injection, or 2 to 3 hours, something like this after the injection.
Sorry, Dr. Hani, is this was with the warfarin or is this was with the NOAC?
There is no NOAC in pregnancy. This chart was warfarin. I am speaking.
Okay,
no,
I'm confused
NOAC
about this. Yeah.
Yeah, the warfarin, the NOAC will be in the next slide.
Okay.
The NOAC in gynae only, it is contraindicated in pregnancy. This is unfractionated heparin. You should keep the woman in the target, and you will adjust the dose according to the APTT ratio, the hemophilia, not the hemophilia, the, what is it? The
INR.
Infraction, infraction.
yeah, it has
INR.
the coagulopathy or the target the target coagulation profile. I should keep it always between less than 1.5. If you remember, if it is exceeding this range or the aim of the woman, my aim between 1.5 to 2.5, so I will not change the dose. If it is lesser than this, need to increase the dose. Higher than this means need to reduce the dose. If the patient on unfractionated heparin, I need to make it little bit on the coagulation profile higher, above 1.5. Above 1.5, so I will continue the same rate. Between 1 and 2 and 1.5 multiple of means, or 1.5 normal, so I will add 2 points per kg per hour, increase the infusion. Less than 1.2, so the patient is going to be normal, not in the coagulopathy or not in the blood thinning site, means that it is less than 1. It's going to normal. Going to normal means I am putting here at a risk of thrombosis. So I will need to double or increase the dose. +4, I will add +4 units per kg per hour. If the woman is 70 kg, so I will add 4 multiplied by 70 per hour means 280 units per hour infusion in a syringe pump. And re-pull again after 80 hours and repeat the PT-INR ratio or the APTT, activated partial thromboplastin ratio, after 6 hours. If it is normal in the blood thinner area, I will repeat it after 24 hours. It is more than this, reduce the dose. Reduce the dose, reduce the syringe pump, or reduce the heparin dose to increase or to get the patient again back in the blood thicker, not in the blood thinner. So the target will be 1.5 to 2.5. If it is like this, I will not increase or reduce, and I will repeat the test after 24 hours. More on the normal side, so it's going to the blood thicker, I will increase. Going to more thinner, the blood is more thin, I will stop, or I will reduce the dose. It's some way to monitor the patient on unfractionated heparin, because I can control the unfractionated heparin by control the half-life only 6 hours. That's why the follow-up is 6 hours.
And Dr.
like
we are going to monitor her with the platelets.
Yeah. This patient need to be monitored the
2
platelet
to 3 days, from 4
for
to
2 to 3 days. Yes, for sure, to avoid the heparin-induced thrombocytopenia.
I only remember 3 or 4 indications, like less than 50 weight, more than 90, and recurrent VT, and massive hemorrhage, and also the renal compromise. Is there any other indication for?
No. The unfractionated or the extreme weight, or if the patient have any contraindication or bleeding, risk of bleeding.
Yeah, contraindication also. Thank you.
The NOAC is almost the same, but take care, because sometimes I will not give if there is no risk of bleeding. There is risk of bleeding. Wait, I think it's not here. How to bring this one now? It was in part 3, in bridging part 3. It was in the teaching, bridging, teaching, bridging. Yeah. This is a prophylactic dose. This is the high risk thrombophilia. Yeah, this is the one I want. Medical procedures that associated with risk of bleeding. If no risk of bleeding, I can give the patient here rivaroxaban. Like a pelvic examination, a smear test, or a swab, this is not a risk of bleeding. Minor risk of bleeding means day case. Biopsy, hysteroscopy, leads, myosure, pipal. You see? So this, he will bring, because this is a new TOG in 2021, something like this. So minor risk of bleeding, this I will stop what? I will omit the rivaroxaban day only, on the day of the surgery. And I will put her again after the surgery. She will take the tablet freely, even no more bridging if there is low risk of bleeding or minor risk of bleeding. No concern about the woman will bleed. If she have hysteroscopy and even there is no antibiotic, I will not give her antibiotic. It is not recommended to give any patient with hysteroscopy, cystoscopy, or laparoscopy only if you suspect a sexually shared infection, or there is suspicion of infection, I will give, or there is a swab, any suspicion of infection, I will give antibiotic. Otherwise, the routine to not give any antibiotic for hysteroscopy, laparoscopy, cystoscopy, any minimal invasive, no antibiotic at all. Vulval biopsy, no antibiotic. All this is no antibiotic, unless you have suspecting infection, like you are doing any instrumentation of the uterus and there is sexually shared infection, or the patient is not screened, so I will give prophylactic dose only. Surgery, prophylactic dose only. Cesarean section, prophylactic dose only. Hysterectomy, prophylactic dose only. It is not like your practice. It is not like our practice. The UK practice recommended by the guideline. So I am going to do perineal surgery, augmentin. Cesarean section, cefuroxime or cefazolin, 2 grams. Okay, the prophylactic dose only.
Sir, I want to ask you one question.
Yeah.
Is there any difference between outpatient hysteroscopy and inpatient? Because there
Yeah,
are
the anesthesia chances. Outpatient hysteroscopy is local anesthesia. So you are doing intercervical infiltration or paracervical infiltration. If the patient cannot tolerate this, it will be under anesthesia. Under anesthesia means general.
Yes, sir, that one I know, but they are asking about apexaban, about both cases, that we need to stop or we don't need to
No,
stop.
yeah, the polypectomy, both are the same. You see here, polypectomy, both of them here, you will stop because it's a minor risk of bleeding. Diagnostic or operative. Myosure, this is under general anesthesia. Myosure polypectomy or Novasure ablation, all these under general anesthesia. So both of them have minor risk of bleeding. I will stop 24 hours. I will go back again to the protocol. But I am telling you what is the risk of bleeding, what means minor and what means major. Major means a CS.
Sir, in your talk, I
Surgery.
saw you answered sometimes that no need to stop for hysteroscopy and polypectomy.
No, it's not anymore. It's not anymore. I will stop. I will tell you why. You see here, apixaban or rivaroxaban, and this is the high risk and low risk. If it is normal, I will stop. This is the update in 2020 or 2022, 2021, as I remember. This is the update of the bridging, the RSOG bridging. You see here, rivaroxaban. Here, this is always coming in the exam. Minor risk, normal renal function, 24 hours. Abnormal renal function, 48 hours. And recommend one dose only prophylactic, then I will put it back again to. Does this make sense? Okay.
Yes.
Major risk factor, 2 days or 3 days. So that's why I bring it this talk. Okay, now we are clear about the bridging. I will go to another thing, which is this protocol. Also, it is an RSOG improvement project with the NHS. Again, the NHS have modified. It's almost the same, but in the last exam, they said when you will start the low molecular weight HIPAA. Usually will start after 2 days in post protocol.
48, yeah.
Yeah, 48 hours. In gynae or in In obstetric, I will give a chance for the warfarin to be finished from the blood. So I will start it 48 hours after the last dose of warfarin. In the antenatal or the pre-surgery, the bridging. So stop warfarin, 48 hours, start the low molecular weight heparin. Postnatal, I will continue the low molecular weight heparin and the warfarin together until the warfarin takes the lead or start to give an action. I posted it in the group. This is a new protocol, almost the same, but you see here, usually you will stop 48 hours before the procedure. This is, where is the warfarin? Warfarin. This one. Stop warfarin 5 days. Start low molecular weight heparin 3 days before surgery. So after 2 days. This means the lifetime, or what is the lifetime? The half-lifetime. The half-lifetime of the warfarin
36 hours per warfarin.
is finished already, broken. So no more warfarin in the blood, and the INR will be getting down. Then I will start the low molecular weight heparin. I am giving 2 days for the INR to settle down, to normalize. Allow the INR to normalize, which is the mode of action of warfarin. That's why I depended here. It is the same in antenatal and in gyne. Warfarin, mode of action is the same. So when I will start, allow the INR to normalize. So 48 hours, then I will start the low molecular antenatal or before surgery or before gyne surgery. Does this make sense? This is a new exam which came in the last recall or in the last year. Okay, clear the bridging now. Any question about the bridging?
Hani, just add this logarithm in the lecture, please.
Yeah, because I did it in part 3. I'm sorry, I don't have time to prepare now. Yeah, I spent 4 hours yesterday in one robotic surgery of endometriosis. Actually, it was like animation. Stage 4 endometriosis in the rectum, involving the rectum and the bowel and the vagina nodule. It was robotic surgery, 4 hours doing one surgery. And after that, the surgery continued very late. Okay.
May God help you here.
The problem that I came into an endometriosis center and a lot of surgery is on the list.
Dr. Hani, you're doing the endometriosis.
It's one of the four centers in UK, my dear, the Essex University. Okay. Actually, it is a very nice experience. I enjoyed the hard work, and as you know, but it's not giving me any time to do any other thing.
Yeah, no, in endometriosis, I can understand why I was working last whole year. It takes sometimes 9, 10 p.m. So it's
a lot of tough time. So you cannot continue any activity you love besides work. So any question about what you will do, how to do the bridging? I'm not concerned today about the knowledge, but I am concerned about how you get from the knowledge. I am concerned about your level. I am speaking for 1 year now with you, but I want you to get all the same level of knowledge. So all of you understand everything. If you have any question, please ask before I proceed. The DVT, you know that if I have duplex, DVT is a clinical diagnosis, so I have red, I have hotness, I have tenderness on the calf, so I need to do Doppler ultrasound. Doppler negative, I will stop. If I have suspicious or no suspicious, I will stop. But the difference, if I have suspicious, I will repeat the Doppler again. In any way, I will stop the low molecular weight heparin because the Doppler is negative. But still, the woman is symptomatic, I will repeat the Doppler again in day 3 and day 7. So this is the trick of the exam. There is a big difference here. The big difference about the PE or the pulmonary embolism. Once you have suspicion only, means the woman is breathlessness having difficulty or having changes or cannot breathe or having difficulty in walking, or she cannot, any symptoms or post-surgery or post-symptoms of DVT or previous DVT, all these are high suspicious of pulmonary embolism. What I will do, clinical assessment, yes, breathlessness, so chest X-ray, ECG, and the pre-test, full blood count, electrolyte, liver function. Once I continue at the pre-check in the ER, I will start the low molecular weight heparin in therapeutic dose, not prophylactic dose here. Don't kill me. It's a pulmonary embolism. And I need with me a VTE specialist, a hematology. So I will not manage a medical, a multidisciplinary team. I'm not managing pulmonary embolism alone. So I need an MDT, which will be the medical doctor, the ICU doctor, the hematology doctor, and me, because the patient is pregnant or postpartum. Okay? Assessment, pre-investigation, then low molecular weight heparin therapeutic dose involves a multidisciplinary team. I am expecting one exam question here. Symptoms and signs of DVT, for sure, I will do the Doppler. Doppler positive, continue. Doppler negative, I will go to the chest X-ray. This chest X-ray. Is it normal VQ scan? Is it abnormal CTPA, which is increasing the breast cancer? breast, increasing the chances of breast cancer. And this is increasing the chances of childhood cancer. Pulmonary embolism, confirmed, continue. Excluded means all these are negative. Okay, the woman resolved, reassured, finish, stop the low molecular weight heparin. Still you have suspicious, continue the low molecular weight heparin and repeat the test again. This is
no, but Dr. Ani, here we will stop we will not continue in the DVT. And in the PE, we will continue. In DVT, we will stop and we will repeat the test.
This is the DVT.
Yeah, DVT one.
If it is negative, I will stop.
Yeah.
Positive, I will continue.
That's true.
This is the pulmonary embolism.
Okay.
High suspicion, continue. Low suspicion, the woman resolve it, I will stop. Any question here? Okay.
Sir, do you remember the percentages of incidence of this breast cancer and childhood cancer?
No, it's very difficult. I'm getting old, my dear. I'm almost 50 now.
Problem, sir.
I think it's 1 in 300,000, something like this. I will not discuss the old screening now. I think it's obsolete. No more cervical screen. It's only human papillomavirus. So the human papillomavirus will be the start always. No more cervical screening. Actually, human papillomavirus negative routine recall, which will be every 5 years. Until now, it's not yet. It is before 53 years. After 50, it's 5 years. Who is doing the cervical screening program? Actually, the GP. The GP is applying this. If he have abnormal human papillomavirus, he will refer, or he will take a cytology. Cytology came abnormal, at that time he will refer to colposcopy. If it is negative, repeat what? After a year, repeat what? The human papillomavirus. If it is positive, cytology. Abnormal, colposcopy. Normal, repeat after a year. If it is persistent for 2 years, means the woman cannot clear the human papillomavirus for 2 years. This will put her at a higher risk of having VIN or CIN, so colposcopy referral regardless of the cytology. These are the GP rule or the new chest screening. Clear? As simple as that. Human papillomavirus positive, cytology. Positive, colposcopy. Negative, after a year. Why? Cytology negative, but the human papillomavirus is positive. So I will repeat the human papillomavirus after a year. Again, positive, I will do cytology. I will not refer the woman to colposcopy unless she have 2 positive, human papillomavirus and cytology. Abnormal. Okay? To reduce the colposcopy referral, because the waiting time on the colposcopy and in the menopausal clinic is almost a year. 52 weeks. So after the patient have human papillomavirus, unless she have a lesion to put her in the fast track, in the 2 weeks track, what she have a CGIN or CIN 2 or 3, or she have invasive cancer, so it will be on the track, so it will be seen in the cancer waiting time within 2 weeks. Not this one. This one is routine. Routine referral 6 weeks or even up to more than this. The colposcopy clinic is very busy, and the menopausal waiting time is 1 year. The colposcopy can up to 6 months, not 6 weeks. The routine referral. Unless the patient is on the fast track in anything. The fast track for bleeding, like postmenopausal bleeding and colposcopy and all this will be within 2 weeks. The fast track for ovarian cancer within 2 weeks. The fast track for cervical cancer, 2 weeks. Any suspicious of cancer, you will put the patient on the fast track, which is the cancer pathway. The patient should be seen and treated within a month from the diagnosis. This is called the cancer waiting time, a month. And that's the time of referral only 2 weeks. Okay? CIN1, I will not treat. I will never treat. I will go to this chart because this is the most important chart. CIN1, I will not treat. I will do what? Annual cytology. Annual hemopapillomavirus. Positive cytology. Positive referral to colposcopy. Negative discharge. Hemopapillomavirus negative. Routine recall, 3 years recall. Okay? I will treat CIN2 or 3 or CGIN. And once I treat, I have test of cure after 6 months. Negative 3 years recall, positive colposcopy. As simple as that. Don't complicate things before the exam. CIN2 or 3, see and treat in the colposcopy. So I will do a treatment, leads. Once I have a treatment, test of cure, the new test of cure will be hemopapillomavirus. Negative 3 years recall, positive colposcopy. Any positive test after treatment, higher chances of recurrence colposcopy. I will not do cytology again. This is after treatment. CGIN, 2 test of cure, 2 hemopapillomavirus, 6 and 12. 6 negative, 12. 6 negative, 3 years recall, always coming in the exam. Positive colposcopy, any abnormalities, annual follow-up for 10 years. Or re-excision. If it is CGIN, cytology, abnormal, referral to colposcopy. If not done before, if the patient no re-excision, she will not have a cone, so complete follow-up. Follow-up by what? Hemopapillomavirus. And this is the colposcopy referral. The fast track and the low track. The fast track, 2 weeks. The low track, 6 weeks. Actually, it is more than this. It's up to 6 months. If it is routine, low grade hemopapillomavirus. So the colposcopy referral here is routine, no urgency. Any urgency, like high grade dyskaryosis, CIN2, CIN3, CGIN, or invasion, 2 weeks. High risk for gynae, ovarian cancer, cervical cancer, endometrial cancer. This is a fast track for gynae. Referral to gynecologist within 2 weeks. If she have any other endometrial cancer, cells from other origin, endometrial. Okay? So the low track or the routine track is 6 weeks or even more. The fast track from here, from CIN2, high grade, moderate. This will be in the fast track. High grade, severe, CIN3, dyskaryosis. Invasive, CGIN. All this is 2 week. What you will do as a colposcopy? 2 consecutive negative. Every time I will change. This is old. 2 consecutive inadequate. I will go for colposcopy. Borderline abnormal, any abnormalities with hemopapillomavirus, colposcopy. Mild dyskaryosis, moderate or severe, colposcopy. Moderate dyskaryosis, CIN2 or 3, colposcopy. High risk of invasion or CGIN, colposcopy. After treatment with hemopapillomavirus. He didn't say cytology. Any hemopapillomavirus positive after treatment at test of cure means colposcopy. The colposcopy, as we said, it is 2 stain, local iodine and vinegar, acetic acid and local iodine, to paint the cervix and have a look for any suspicious lesion. Mild biopsy, CIN1 biopsy. Coarse, CIN2 or 3, treatment, leads, or CGIN. Mild biopsy, punch biopsy. CIN2 or 3, treatment. This is the leads. And this is what we have discussed about the practice in UK. Abnormal, this is for gyne. Abnormal referral to gyne. Severe or moderate dyskaryosis, colposcopy. High grade, see and treat. Low grade, biopsy. Colposcopic appearance of normal or low grade biopsy, multiple punch biopsy. It came CIN1, follow up, CIN2 or 3 leads, high grade leads. After treatment, test of cure, hemorrhagic positive colposcopy, negative 3 years recall. The same. But I love this because this is onto the target. Moderate dyskaryosis, severe dyskaryosis, or CGIN, colposcopy. High grade, or CIN2 or 3 or CGIN leads. And the follow-up will be human papillomavirus positive colposcopy, again, negative 3 years recall. This is the target. This is how I will do. Borderline nuclear or mild dyskaryosis, human papillomavirus, negative routine recall, positive colposcopy. And according to the appearance at colposcopy, low grade bunch biopsy, CIN1 discharge, annual follow-up, CIN2 or 3 treatment leads. Wow, to the point. This chart is to the point, to the exam. This chart is to the exam. Does this make sense why it is important? It's up to date and to the exam. Human papillomavirus, cytology. The cytology, if came borderline high grade colposcopy, according to the what you will see in the colposcopy. CIN1, biopsy. 2 or 3, treat, leads. After treatment, human papillomavirus. Positive, colposcopy again. Negative, 3 years recall. Does this make sense? Easy. This is the cancer pathway, the GP vision. The GP vision. This patient on the track or in the routine. High risk of cancer, like suspected pelvic mass, pelvic lesion, 2 weeks RAC, rapid access clinic. Need hysteroscopy. The indication for hysteroscopy, persistent intramenstrual bleeding more than 34, failure treatment, or fibroid, need removal and background, or need hysteroscopy for any postmenopausal bleeding with HRT, all this. So I will put here in the rapid access clinic. Hysteroscopy and biopsy and propectomy and background biopsy if she don't like to have fertility ablation, if she have bleeding, or hysterectomy. No any suspicious, you will do full blood count and ultrasound and prescribe Mirena or combined oral contraceptive pills for 3 months. This is the management of heavy menstrual.
Sir, I want to ask you one question here.
Yeah.
In the recaps, there is one scenario with postmenopausal bleeding and intermenstrual bleeding and age more than 45. So, sir, they are giving 2 options. We will do directly hysteroscopy or we will do TVS first.
If there is indication for hysteroscopy, you will go for hysteroscopy. These are the indication for hysteroscopy. As I told you before, let's bring this is the indication for hysteroscopy, means you will go direct for hysteroscopy.
This is the indication in intermenstrual bleeding and these things. So we will not select TVS there.
No Bible. If not clearly like this, because it will come in the exam clearly like this. Because he put the indication for hysteroscopy to bypass the Bible, my dear. If this patient came like this with this criteria, means hysteroscopy. Indication for hysteroscopy. Abnormal menses more than 45, direct to hysteroscopy. Postcoital bleeding despite normal cervix. So he will tell you the patient have postcoital bleeding and the GP examined her and the cervix appears normal, hysteroscopy. History of fibroid or polyp, hysteroscopy. To remove the polyp and have a background.
Sir, if this patient is less than 45 years, then we will do TVS.
Again. Yeah, it should, the criteria should be met, my dear. Yes. The bleeding, irregular vaginal bleeding, but the patient is not obese or not more than 45. So no indication. because you see here, persistent intermenstrual bleeding or irregular bleeding despite normal cervix. He didn't highlight here, is it more than 45 or no? It is not responding to treatment here. And the patient is obese or PCO or tamoxifen. So this is indication for hysteroscopy. Because this
one I saw more than 45 years on CHC, continuous hormone, and she's coming with intermenstrual bleeding. So there, what we will do, hysteroscopy.
that hysteroscopy. Why, Shanza? I told you hysteroscopy because the combined oral contraceptive pill should control that bleeding. So this is a failure of the treatment. Does this make sense?
Yes, sir. Yes,
so
sir.
This is a failure of treatment. So referral to colposcopy, hysteroscopy is indicated. So when it will come 40 years, he will tell you that the patient is 40 years, have heavy menstrual bleeding, not responding to treatment despite of normal cervix, and her BMI is 40. Now, indicated.
Sir, there come wait time also with CHC, I think 6 months or 3 months.
3 months. 3 months
Yeah.
is you can expect bleeding. After that, the patient is not responding, you will refer her to hysteroscopy.
So if within 3 months, so we will reassure only.
Yeah, it can be up to 3 months because the treatment is 3 months of non-steroidal or 3 months of combined oral contraceptive pills or tranexamic acid, according to the bleeding, heavy menstrual bleeding NICE guideline. So if you have this one as well, postmenopausal bleeding, especially if the patient is persistent or recurrent with tamoxifen or the endometrial thickness more than 4, or the Bible have abnormality, and the Bible have abnormalities, or the Bible have difficulties. All these are the indication for hysteroscopy. I am sure you will have 2 or 3 questions from this slide in the exam, because even in the RCPI, they love this slide. In the SPA, you will have 2 or 3 from this slide. I'm sure, 100% sure. What you want, Mariam? The file, okay. The file already in the website. This file already in the website. If you want it, I will make it a file and put it, but don't share. I will put it in the group, no problem. It's just pictures. I have no problem. I will post it. Okay. So now we finished up to the bleeding. What is this? The leads. They loved this slide. A patient have a leads, and on the margin there is CGIN, repeat leads. On the margin there is microinvasion, repeat leads. Her age more than 50 with unclear margin. There is CIN3 in the margin, but the patient is more than 50. So repeat leads. Otherwise, human papilloma virus in the community after 6 weeks. Okay. Colposcopic evaluation for a pregnant woman. I will tell you a story of a patient which always coming in the exam. The patient have CIN2 or 3 treated before pregnancy. Do I need to do test of cure in pregnancy? Yes. When I will do it, I will do it after the first trimester, but it will not be test of cure because of the pregnancy changes on the neck of the womb or in the cervix will change the biopsy, the smear, and everything. So I will do what? Colposcopy. When I will do the colposcopy in the second trimester. Why? My nightmare that this woman will have invasion means 1A1, not CIN2 or 3 or CGIN even. All this can be followed up. I will repeat colposcopy in the second trimester and in the third trimester, 28 weeks. My nightmare in pregnancy, that woman may develop invasion. So I will interfere in pregnancy, which puts the woman at higher risk of bleeding and high risk of preterm labor and all this. So I am doing colposcopy mainly to rule out invasion. For whom? Woman who is already treated or have abnormal smear or abnormal screening before pregnancy to rule out invasion. Be smart. I'm not doing follow-up here to see I will treat or no. I need to see is this patient will develop to invasive cervical cancer in pregnancy, so I must treat her. Otherwise, I will defer the treatment after pregnancy. So this is the scenario, how it will come in the exam. The main benefit of colposcopy is rule out invasion. When I will do the colposcopy, if there is test of cure is due to 6 months treatment before pregnancy, I will do it in the late first, early second, at 12, 13 weeks. If I find CIN1, kick her out after pregnancy, 3 months. CIN2 or 3 or CGIN, I will repeat colposcopy at 28 weeks to do rule out invasion. Any invasion find, so treatment. Clear why I am doing colposcopy in pregnancy? I am doing colposcopy not to treat leads or CIN2. It's different here, the patient is pregnant. So I have a main aim here to rule out the invasion. Okay, my dear? Clear? So I will repeat colposcopy. I will not treat until I have invasion in pregnancy. I will do colposcopy at 12 and I will repeat it if it is CIN2 or 3. I will repeat it at the late second trimester, 28 weeks. I will not interfere unless there is invasion, so I will treat. And I will treat in tertiary center who can stop the bleed. The post-hysterectomy follow-up according to the new one, leave this one. I will go direct to the new one. Why? Because this came already in the exam. No CIN1, only volt sample at 6 months. If this volt sample is positive, I will do colposcopy. Negative discharge. CIN1 present in the semen, completely excised, in the specimen, completely excised, not 6 and 18. 6 months volt sample. Sample means a swab for human papillomavirus PCR. Positive, colposcopy. Negative discharge. Why colposcopy? To rule out VIN, vaginal VAIN, because there is risk about 3 to 4% after hysterectomy to have a vaginal invasive cancer or intraepithelial cancer. So I will do colposcopy, volt sample at 6 months. If positive, colposcopy. Colposcopy negative, discharge. Okay? The CIN1, but incomplete excise, means that there is margin unclear. Is it CIN1, 6, 12, 24? And we put 100 pound here, and Farida until now didn't pay it. CIN2 or 3, so 6, 12, and annual thereafter. Because the margin is unclear, incompletely excised. Completely excised, colposcopy, 6 months. Incompletely excised as the cervix is there, 6, 12, 24. If it is CIN1, CIN2 or 3, it will be 6, 12, and annual. Until what? 10 year or 65 year, which is far from the treatment. I think you don't need to follow up or to remember the ovarian cancer postmenopausal. Any question here? Any question about the follow-up of ovarian cancer? I'm a little bit running to cover all the therapies. I know that this point is clear. The RMI.
Dr. Hani, here in the ovarian the ovarian cyst follow-up, we need three
yeah, according to if you are doing it 4 months, if he said for you it is already 1 year, so it is not 3. It is twice.
If you start from on the top, the first one, there's 1, and then second is there on the left, and the third is the persistent, if it is persistent.
If he said the cyst is persistent for 1 year without concern, discharge. There is concern bilateral salpingo-oophorectomy. Persistent for 1 year. No concern, discharge. Any concern, intervention. Any change, intervention.
And the
solve
middle
it,
part,
discharge.
if there's any one feature, our patient is symptomatic, she will directly
Finish. Bilateral salpingo, bilateral salpingo. I want you to remember that this is a scoring system. The ultrasound score, multilocular, solid, bilateral, ascites, metastasis. It is not the size. The size of the cyst makes no difference, only in the treatment here, not in the score. In the score, the RMI. The triaging, the RMI. This is the triaging. So the one responsible for triaging and managing patient is IUTA. He write here IUTA. He depends in IUTA here in triaging and managing patient.
RMI.
No, the RMI. So why I will answer IUTA? IUTA is nothing. IUTA is giving you sensitivity for picking up the criteria of malignancy, vascularity, bumping cervix, papillary projection. So I love IUTA. It will give you a hint of malignancy, but it is not responsible for triaging. This will go here and this will go here. This will go here and this will go here. The RMI. This is the triaging here according to the RMI. And remember that the size makes no difference in the triaging. Okay? Multi, solid, metastasis, ascites, bilateral.
Sir, here I want to ask you one question.
Sure.
Sometimes they are giving in the recall scenario that the patient has cyst 5 centimeter, 6 centimeter postmenopausal, and then they are telling some pathologies in the uterus also, like fibroid uterus. So I will take TH also along with BSO.
Why? Is the treatment of fibroid
Forcing us to go towards that, like fibroid uterus and something like this, and age is more than 50 years. So sometimes I'm confused.
I will tell you something. There is indication for hysterectomy, you will do it. There is no indication, leave it. This is a big different operation. Laparoscopic bilateral salpingo-oophorectomy is laparoscopy, so you can take it here by calotus and here, and you will go out. So it is not a difficult issue. It's easy.
Sir, what is the benefit of
hysterectomy is indicated or not? Indicated means a huge fibroid affecting the woman. There is persistent bleeding. So remove the womb as well. Does this make sense? It's logic. It is indicated to remove failure to medical treatment, myelina failed or cannot be potted. So postmenopausal woman with considering bilateral salpingo-oophorectomy for ovarian cyst, which is painful, and she have a fibroid dragging symptoms, so it will not be laparoscopy. It will be difficult to do. It's open now.
Yes, sir.
So individualize the treatment according to the clinical scenario. Is it indicated? Let's go to the indicated hysterectomy. When I will do hysterectomy? This one, indication for hysterectomy. Persistent endometrial hyperplasia with treatment, medical treatment or myelina. Persistent ongoing bleeding. Hysterectomy plus bilateral salpingo-oophorectomy. Endometrial hyperplasia, even simple endometrial hyperplasia, but there is ongoing bleeding, failure, hysterectomy, persistent, hysterectomy. From start, atypia, hysterectomy. You see?
In this here, the other issues there, they always say plus minus BSO.
Yeah, because of the perimenopausal, not the postmenopausal.
What shall we do? Like what shall we choose then?
If it is less than 50 or even less than 60, individualize the treatment. But more than this, remove it, no benefit. The benefit of the ovary only until the age of 60 to reduce the symptoms of menopause and to reduce the risk of cardiovascular stroke. There is benefit and risk. Would you remove her ovary? I will inform the patient the benefit of removal and the benefit of keeping the ovary. The benefit of removal that she will not need to have any concern about the ovary. She will not develop any ovarian cyst or any ovarian mass or any risk of cancer. The benefit of removal that she will not develop any chronic pelvic pain or left ovary syndrome or ovarian trap syndrome or all this painful chronic pelvic syndrome. So these are the benefit of removal. The drawback, osteoporosis, HRT, menopausal symptoms, cardiovascular risk increasing before the age of 60. So I will offer this, and the woman will choose to remove or not. If the ovary is healthy, but if the ovary is indicated to remove from the start, ovarian cyst more than 5 centimeters, postmenopausal woman which is painful. You are joking. This is a surgery, and you will put the patient into surgery. So endometrial hyperplasia with atypia and postmenopausal ovarian cyst 5 centimeters. Painful. So bilateral salpingio-flexion. Would you going to remove her ovary from the start? I would say no, unless it is indicated. I will put this on the patient table. I will tell her the benefit and risks. This is the benefit to remove, and this is the benefit to leave. Okay? Any question here in the hyperplasia? A lot of tricks actually here. With atypia or without atypia? What is the risk of endometrial hyperplasia without atypia to develop to cancer over 20 years? Less?
Less than 5%.
Less than 5, exactly 2%. So I have option to treatment. The treatment will be Mirena, the first line, or progesterone. Individualize the treatment, and I follow the patient by pill, not hysteroscopy. Endometrial biopsy every 6 months, sorry. If it is negative, 2 consecutive negative, discharge. If the patient treated by Mirena and have a low PMI, discharge. But if treated by progesterone or high PMI, any of these, I will continue annual thereafter. Endometrial hyperplasia with atypia, total abdominal hysterectomy, and bilateral salpingio-oophorectomy. Young, 35, both Mirena or progesterone, and follow up the patient every 3 months. Unless she have 1 negative, refer her to fertility specialist, complete family hysterectomy. Persistent treatment hysterectomy. Persistent hyperplasia after treatment hysterectomy. Even if it is improved from atypia to hyperplasia, but still persistent hyperplasia, which is indicated for hysterectomy after treatment. So he's telling you the patient presented by total abdominal, presented by endometrial hyperplasia with atypia treated by Mirena after 1 year, it is endometrial hyperplasia only without atypia. Hysterectomy, because hyperplasia is still persistent. Okay? Persistent hyperplasia with Mirena itself, hysterectomy. Okay?
And Dr. For the progesterone, we can give up to 1 year.
Yeah, 6 months is follow up to 1 year. It's a continuous.
Sir, there is one question in the recalls that patient did not follow up, and after 1 year she came, she had, before she had endometrial hyperplasia without atypia. And then she did not come, she did not follow up. Then what we will do?
Okay, she continue have Mirena?
No, sir, she did not take any investigation, any treatments.
No.
And then after 1 year she is coming.
Again.
Start the treatment here, my dear. Why? Because she didn't start the treatment. You will be here. Start the treatment after observation failed. In this type of observation, I should play on the risk factor. The HRT, the obesity, the PCO, and the tamoxifen. Reduce your weight. Change the HRT.
But sir, there is option for endometrial biopsy now also. So we will not first do biopsy.
How you will follow up? You already have endometrial hyperplasia, and he told you it is persistent. How he know? A transvaginal ultrasound. Start a treatment, my dear.
TVS we should do first.
It's already persistent. You have from where you know that it is persistent.
No, they are just mentioned that she was diagnosed with this and then she did not come for any
Okay, so
follow-up.
either to do TVS or to have a pipe again.
Yes, and then accordingly we will do
Accordingly,
treatment.
you will see a start a treatment or atypia so hysterectomy. Okay, let's move.
It is start from again from the beginning.
Already we discussed the indication for hysteroscopy, and now I am putting a press again on the hysteroscopy. The 4H, 4T, and 2 in pregnancy, this is a reversible because the PLS. Anybody still without PLS? I think all of you are PLS instructor and also instructor now. Any question here in the CPR? First of all, your safety. Any electricity, any field, any collapse, any water, your scene should be safe. Exam question. After that, shout, call for help, assess the patient. Are you okay? Are you okay? Open the airway, assess the airway, look, listen, and feel for 5 to 10 seconds. No breathing, put the patient in the left lateral, ensure left lateral position or manual displacement. Then start the CPR for 2 minutes. 30 to 2. 30 compression to 2, this is the ratio. 100 per minute, this is the rate. The depth is 1/3 of the chest diameter, 5 to 6 centimeters. 2 ventilation every 30 compression. After 2 minutes, reassess. Actually, the defibrillator will tell you, stop now. Remove your hand. Reassess. Then he will tell you, VTAC, ventricular tachycardia. Shock is advisable. Deliver the shock when it is safe. So everybody will clear. Remove your hands. Deliver a shock. Shock delivered. No reassessment. Start CPR for 2 minutes. After shock. 1 shock, 200 biphasic or 360 monophasic. CPR for 2 minutes. After CPR, no more reassessment. The patient is pregnant, pre-mortem cesarean section. Okay. Any question about?
Dr. Ali, the
Yeah.
most common cause of the collapse and then these few and the types of the maternal death, direct
Yeah,
and
the most common cause of collapse is vasovagal and epilepsy.
epilepsy. Okay.
The most common cause of this, is it direct or indirect? Direct VTE, indirect cardiac in pregnancy. So collapse is different than this. I think postpartum hemorrhage is, now you are expert in management of the postpartum hemorrhage. It's a protocol. It is not a one-man show. It's a protocol. It's a group. It's a multidisciplinary team. It's not me at all. I am only a part of the team. So major progression of postpartum hemorrhage more than a liter in postpartum, I will call for help. Call for whom? For the multidisciplinary team. Midwife, obstetrician, anesthesia, hematology, blood bank, and alert the consultant on call if he's not here. Resuscitation, airway, breathing, circulation, and the fluid balance. And I will speak about the fluid again. 2 liter crystalloids, then 1.5 liter colloid, then O negative, K negative blood until the blood product or until the fresh frozen plasma is coming. 4 to 4 or 4 to 10 to 15 according to the coagulopathy if I have a PTT ratio or no, the blood product. Keep the patient warm and simultaneously act. The monitoring, which is 14 cannula, full blood count, coagulopathy, 4 units cross-matching, the ultrasound, the Foley catheter, the bedside hemoglobin, and weigh the swabs and the recording, the scrub nurse or the scrubler, which is recording. And the treatment. The first medical treatment, uterine massage, empty the bladder, oxytocin 5 IV can be repeated, ergometrine if the patient is not hypertension, oxytocin infusion if there is atony, carpoprost if the patient is asthmatic, I will omit the carpoprost and I will go for misoprostol. Misoprostol contraindicated in asthma? No. Carpoprost, the hemapate, is contraindicated in asthma. Misoprostol, no. Consider tranexamic acid 1 gram, yes. If the patient is not responding, I will go to the theater. Already I am the theater, so I will put bacripione, examination under general anesthesia, and bacripione. While I am putting bacripione, the patient was suturing, and they broke the Beckley balloon. They touched the Beckley balloon with a needle. So what you will do, finish the suturing. They was doing a P-wrench, and I did Beckley balloon, and the registrar touched it. There was a water coming from the wound. So I thought, stop. You sutured the Beckley balloon. I removed the Beckley balloon, then I put another Beckley balloon after they finished the suture. Tamponade, intrauterine balloon, and breast suture, both sides, about 90% effective. After that, actually, it is a magic. The patient does not stop bleeding. It was a placenta previa. So, intervention radiology, it was, again, a very nice experience. In my previous experience, we were doing hysterectomy here, bilateral uterine artery ligation, failed hysterectomy. Intervention radiology is a magic. Prophylactic bilateral internal iliac ligation with a foam, which can be dissolved within 6 weeks. Wow. Reversible ligation. Wow. This is the tertiary center can deal with placenta previa, can deal with placenta accreta. Prophylactic 24-hour intervention radiology did bilateral internal iliac ligation with a gel foam, which came like a shutdown. Close the tape. No more bleeding. And it is resolvable, reabsorbable. 6 weeks, the patient will gain again their internal iliac, and uterine artery will be fine, and everything will be fine. Failed, no bleeding, stepwise. Uterine artery in one side, post-uterine artery, low uterine arteries, internal iliac, hysterectomy. 2 consultants should be here. So this is the flow chart of managing. What about the resuscitation? You said 2-liter crystalloid, hemapate, ringer, normal saline, D5 normal saline, it's crystalloid, and 1.5 liter colloid. Until your blood is here, O negative, K negative. Cytomegalo. Cytomegalo is an elective, my dear, not in the emergency. O negative, K negative, unless you have a group specific. You have already a 4 units cross-matched before, so give cross-matched blood. You don't have uncross-matched blood. 4-4 if you don't have the PTT ratio, you don't have a blood. So 4-4, 4 unit to 4 unit to restore the coagulopathy in dark, impliedness. But you have, so I know I should keep the aim, the target. The target is 1.5 or less PTT ratio. If it is less, I will give 12 to 15. If it is more than that, I will give more than 15. So 4-4 is a one working in the ward or working in without the multidisciplinary teams. The hematology does not yet appear. The blood bank is not yet a result appear. I don't have a result. So 4-4, 6-6, 8-8. I have a result, and the result is 1.5 multiple of means, give 12 to 15. More than this, more than 15 to restore the patient. Platelet less than 75, 1 pool of platelet, not 1 unit. Fibrinogen less than 2, give 2 pools of cryoprecipitate. Any question here?
Sir, I have one question here.
Sure.
One question, I saw that the patient had a major PPH, but now she has settled and bleeding stopped. But
That's fine. See the parameter. The parameter is fine. No, nothing more.
Rearranged, platelets less than 50, and this fibrinogen
Wait. What is the parameter again?
Platelets less than 50.
No, I will give 1 pool of platelet because the parameter I have a range, my dear. I have a target.
Here they given one line if the bleeding is ongoing and this.
Wait. This is mentioned in the guideline itself. Just a second. I have an aim. I have a target. I should this is
But in the chart they mentioned this line, so I'm always confused that if settled, then
yeah, if settled, I will stop the treatment, but I should keep the patient on the safety margin, on the target, hemoglobin more than 8, cryoprecipitate or the fibrinogen more than 2. So otherwise she will bleed again. This is the protocol. and I give the target. Aim.
Yes,
Aim.
sir. That one I know. That one I know. The targets they given for antenatal and postnatal. But only confusing thing is that in the chart you shown, they mentioned that if ongoing PPH.
Yeah, ongoing, I need to continue the resuscitation until I stop the bleeding. I stop the bleeding and I am away from the target, so the hemoglobin less than 8 or the platelet less than 75, I will give my.
Yes, sir. Okay.
This means the patient may develop coagulopathy, so I need to
Yeah, but
restore.
Dr. Ani, like they have already given fluids and blood, everything. Now the patient is bleeding is stopped, and they mentioned the fibrinogen is still 1.5 platelets. We got the target at 50. Then what is the purpose to giving extra fibrinogen?
To restore the patient. You see, I need to restore the patient. The aim to maintain the platelet count above 50, but I will transfuse. The trigger will be if it is less than 75. So I need to give platelet here. The aim to maintain the fibrinogen more than 2. Aiming the fibrinogen more than 2. If it is less than this, I will give 2 pools. The pool is 2 5 units should be administered. Usually,
yeah, but the platelet was normal. The fibrinogen was 1.5.
1.5, I will give cryoprecipitate.
Okay.
So according to the target, I need to put the patient above the target, otherwise she will bleed. If she is not less than normal and 1.5 normal, I will give the fresh frozen plasma. You see here, the fresh frozen plasma, those 12 to 15 should be administered for every 6 units of blood during the major hemorrhage. Suspected fresh frozen plasma should be guided by the result of the clotting. If the clotting time aiming to maintain the PT-PTT ratio less than 1.5. Less than 1.5, I will give 12 to 15. More than 1.5, I will give more than 15. All this to restore the coagulopathy.
Okay.
It is mentioned in the session, but we don't have the aim or the targets mentioned in the guideline. The 4 aim, which is my target to restore. This is a blood transfusion.
Yeah, it's given here in the guideline also.
Yeah. This is the one, I think. The plasma fibrinogen should be greater than 2. Cryoprecipitate for replacement. Postpartum hemorrhage, the platelet should be more than 75.
You are not reading completely. It is written during ongoing PPH. It is written in the line. During ongoing PPH. They are always bringing tricky questions.
You mean that if the bleeding stopped, I will not restore the woman?
Yes, sir, because in the scenario they are focusing that now bleeding settled, patient is stable, but the values are deranged. What you will do?
I will restore the value because the patient will develop DIC.
But in the guideline, they didn't mention anything like this about. Sir, every line with deranged values they are mentioning during the ongoing PPH. Everywhere they are mentioning this thing. So maybe in their mind, if there is no bleeding, so we will not do anything.
I am not happy with it because if the patient is outside of the normal range, I need to restore the normal range.
Maybe, sir, after 2 hours or 4 hours, there is something that she will recover spontaneously.
From where she will recover spontaneously?
Like natural, sir, natural healing. Maybe blood will make the products. Because all the guideline, anywhere you go, they are mentioning this thing with the deranged values, ongoing PPH.
This is the main therapeutic goal which I need to restore it. What's this? It's not searching. It's not in the guideline or what? If I didn't, my idea or why I'm telling this, because if I didn't restore the woman from coagulopathy, she will develop DIC. So if the PTT above 1.5, I will leave the patient in the from where she will got again the fresh frozen plasma, from where she will got the cryoprecipitate, from where she will got the hemoglobin. I can wait if the patient is not bleeding and the hemoglobin is 7. Even that will put the patient at a risk because she dropped from 10, 12 to 7. This is a massive. Anyway, this is my approach.
Sir, there they mention, I think, hemoglobin 8 or 8.5, something like this in that question. I'm
So
telling you.
no more blood. Okay, no more blood. The PTT ratio not between 1.5. I will give frozen plasma because the patient already in coagulopathy. I will put the patient on the target. This is my approach. Otherwise, the patient will proceed for. She may bleed again. Does this make sense?
Yes, sir.
So my concern only to keep the patient on the target. I'm sure that here the bleeding is ongoing. The bleeding is ongoing, I will give one pool. The bleeding is ongoing, I will keep. If the bleeding stopped, I will not give. She is one fibrinogen. Fibrinogen degraded already. From where she will got a fibrinogen? That's why I think this will be the best option, the best answer. Anyway, it's your choice in the exam. What you feel is the best answer, do it, because sometimes he play by the word, the words.
Sir, I want to choose what you will tell us.
I'm not in your shoes, so some of my choice, I'm not a full percent. Even the highest knowledgeable consultant in UK will not get 80. The RSOG consultant itself, if he did the exam, he will just pass. You are knowledgeable than them, even than me. Now you are studying. I stopped studying. I'm only reading for fun. But you are
Only
reading for
this thing was coming in my mind. Maybe after 6 hours, spontaneously, it will recover. Is
It
there
will
any
bleed.
chance?
It will bleed again, Shanza. My opinion, it will bleed again, not to recover. From where she will recover?
Her body will produce naturally these things if there is deficiency.
From
I
where?
think not by hours. This the body will restore after a days. Even this RBCs after 120 days like
This
this.
is what
يعني.
I'm telling. From where? From where
Yes.
she will bring?
And already there will be consumption of this all platelets and
That's why I'm telling the patient will go more for the coagulopathy side,
yes.
not in the restoring side. If the bleeding stopped and she's out of the target, I will bring her back. This is my thinking. I'm not 100% sure, but you should feel what is the proper answer in the exam. This was the last point in the fresh frozen plasma. After that, the GPS, the VBACK. Yeah, still. The GPS, you are better than me actually in the GPS. What you will do if you have a preterm labor? Offer a GPS. For sure, any preterm labor, offer intrapartum antibiotic prophylaxis. Any previous infant, offer intrapartum. But any previous carrier, we discussed this, it will be 50% as a carrier this time. What you will do? Offer her a test? No. I will offer her intrapartum antibiotic prophylaxis first. If she refuses, I will give her a test. Wow. Why? Because the intrapartum antibiotic prophylaxis is more safer. The test will give her the chances either 1 in 800, 1 in 400, or 1 in 5,000. The recurrence, if she have a previous baby, untested, 1 in 700 to 800. Positive test will increase to 1 in 400. Negative test will increase to or will reduce to 1 in 1,000 and 5,000. Needs no intrapartum. I don't need to do a test. I will offer her first the intrapartum antibiotic prophylaxis. If she agrees, that's fine. Safer for her and for the baby. The delivery is at term, and she have a history of GPS in this pregnancy. Pre-labor rupture of membrane, give her. Known GPS carrier in this pregnancy, give her. Unknown or negative, no need. At term and she is in labor without rupture of membrane. No risk, no carrier in this pregnancy, give. Fever, pyrexia, broad-spectrum antibiotic, not intrapartum. Broad-spectrum means penicillin or cephalosporin plus or minus metronidazole. So I will give her according to the spectrum, broad-spectrum antibiotic, according to the unit protocol, to guide against, or I will activate the sepsis to protect her from sepsis. That's why I'm giving broad-spectrum. Cover the GPS and other organisms. Only GPS in current pregnancy, no fever, intrapartum. GPS bacteriuria, he didn't say in the rectum or in the vagina. Bacteriuria, treat in pregnancy and offer intrapartum. GPS bacteriuria more than 100 colonies. Cesarean section, no need. These numbers are very important, which I mentioned most of it. What is the likelihood of the success rate? No, there is another number for the GPS. I will bring it. What is?
Sir, for GBS, I want to ask you one question. There is one question that a patient, her friend had GBS and she had complications. Now she is asking you to screen because she is afraid.
Yeah,
sir,
no
here-
screen, no screen, no screen. No screening for her, my dear. No screening for maternal breast. No screening.
Okay.
Offer her counseling. No screening unless she have a previous GPS, a previous carrier, a previous infant. This will be a screen. Where is it? I'm searching for what? Yeah, the number.
GBS number,
This is the number.
incident.
The overall incidence is 0.5 in 1,000. The previous baby is the incidence 1 in 700 to 1 in 800. If she tested positive, 1 in 400. If she tested negative, 1 in 500. That's why I will not offer her intrapartum antibiotic prophylaxis. If she have a fever, the risk will be higher, 5 in 1,000. That's why I will give her intrapartum broad spectrum, not benzazine, penicillin, or penicillin prophylaxis. Okay. Any other question in the GPS?
Sir, just I want to ask you where we are doing immediate induction of labor in
If the patient
GBS.
rupture of membrane at term with a GPS or HIV, I will give immediate induction. If this herpes or HIV or GPS at term, I will give immediate after 37. Between 34 and 37, the benefit outweighs the risk, so immediate induction of labor. Before 34, no. Prematurity will kill the baby.
After 34, we are doing.
Before 34, after 34, I will give 35 plus. I will give immediate induction of labor. Benefit and risks.
But here in GBS, we will do normal vaginal delivery if confirmed positive also.
Benefit outweighs the risks. If the patient less than 34, I will not induce her. More than this, I will induce. The standard antibiotic prophylaxis and allergy also will come in the exam.
We will aim for vaginal, even if confirmed positive, we will aim for vaginal delivery.
Yeah, because you will give induction, immediate induction and immediate antibiotic prophylaxis.
Yes, sir. Okay, thank you.
3 gram intravenous penicillin and give as soon as possible from labor, and after that 4 hours, every 4 hours. If she have fever, I will give broad spectrum antibiotic. If she have allergy to penicillin, so according to the allergy, if it is vomiting only, penicillin. If it is mild allergy, cephalosporin, cefuroxime, 1.5 gram, loading, then 750 every 8 hours. If she is urticaria or respiratory angioedema, severe anaphylaxis, distress, I will give vancomycin, 1 gram every 12 hours. These are overall called standard antibiotic prophylaxis, according to the protocol, according to my unit protocol, the standard antibiotic prophylaxis. If she have rupture of membrane only in preterm, you see expectant management. Erythromycin until she is in labor, I will give her intrapartum antibiotic prophylaxis. GPS. A lot of tricks. Any other questions? Broad spectrum antibiotic. If she have fever, the risk will be higher, 5 times higher, instead 0.5, 10 times higher. Instead 0.5 to 5 in 1,000. Either amoxicillin 2 gram or cefuroxime 1.5 every 6 hours. Broad spectrum antibiotic to cover other GPS or other types of infection if the patient have fever. Okay. Go back again to our file. The VBACK, 1 in 4, 1 in 200 rupture uterus, previous vaginal delivery, if it is before the CS 85, after the CS 90, 64, 74, 84, cervical dystocia, fetal distress, or malpresentation. The placenta previa, I think already we discussed the placenta previa, and you are aware about the trick, which I will not do. Any patient with placenta previa and previous cesarean section, I will do a color Doppler at 32 weeks. Once confirmed accreta, refer her to London or Cambridge. I am not an accreta center. Unless the patient came in a critical scenario, so you should have, it's unsafe referral. She will die in the ambulance. So this is another scenario. A bleeding patient should not be referred unless the patient is suitable for referral. Does this make sense? So placenta previa only low-lying at the anomaly scan. If it is posterior or high PMI, I will do transvaginal now at 20 weeks. If it is high PMI more than 35 or the placenta posterior, I will do transvaginal now. Okay. At 32 weeks, placenta previa only, I will repeat transvaginal. I find previous scar due to breech, color Doppler to rule out accreta here at 32, not at 36, at 32, because at 34 she will be in London or in Cambridge, in accreta center, who has the 6 good practice and the 3, what is the 6 good practice and what is the 3 good technique? Who remember? Who remember? The good practice for previa and accreta. And the 3I or the 3P. What is the good practice? And what is the 3P? Who is the brilliant candidate will tell me? The 3P, which is preoperative localization of the placenta, preoperative pelvic devascularization, and placental non-separation. These are the 3P. What is the good practice? Consultant, blood bank, hysterectomy, intervention radiology, and what else? 6. Consultant, hysterectomy, blood bank, intervention radiology. Still there is 1. Bring the placenta brief. Level 3. Excellent, sir. Level 3 ICU. Yes, I forget it. So this is the good practice management of placenta previa and placenta accreta, and consultant obstetrician, consultant anesthesia, blood bank, ICU, and intervention radiology. All this should be available before I touch a patient with placenta previa. This is the chart you are hating, which is post-emergency cesarean section, postpartum hemorrhage, or postoperative complication. What I will do, the patient have acute abdominal distension, acute colonic pseudo-obstruction, Ogilvy syndrome, or paralytic ileus. Conservative treatment. First of all, baseline, full blood count, uroelectrolyte, C-reactive protein, and lactate, chest X-ray, and abdominal X-ray. Electrolyte imbalance, the most common cause. So conservative measure, nothing by mouse, correct the electrolyte. Surgical review is the first exam question here. After investigation, surgical review. If no any emergency, no tympanic abdomen, no air under the diaphragm, no perforated viscous, all these two will put her in the theater. No, she's stable. No air under the diaphragm, not in sepsis, so she is not going to the theater. Investigation are fine, chest X-ray only distension. So surgical review, nothing by mouse, electrolyte imbalance, fluid imbalance, mobilize the patient. Corrected, continue. Not corrected, CT and neostigmine for 24 hours. Corrected, continue. Not corrected, colonoscopy, decompression. Any emergency, put her in the theater. Amenorrhea. Amenorrhea with secondary sexual character or no secondary sexual character. No secondary sexual character, no, so there is a problem. FSH is low or high. Measure the FSH. Low, hypogonadotrophic hypogonadism. High, either ovarian failure or terminal. There is secondary sexual character. Ultrasound, uterus present or absent. Uterus present, either secondary amenorrhea or cryptomenorrhea. Secondary amenorrhea like PCO or Cushing, cryptomenorrhea like imperforate hymen or imperforate septum. Uterus absent, karyotyping, male or female. And here we did another chart, which is the reduced secondary sexual character or normal secondary sexual character in Merck and androgen insensitivity. The ulcers I will post this in the group. Already we speak about it. The HIV multiple Schary ulcers. The syphilis is single firm non-painless ulcers. The chancroid marked painful ulcer with inguinal, 50% inguinal, unilateral may be ulcerate. Lymph granulum and venereum usually painless, and there is shallow, small, fleeting, or matted, pupone matted together. Granuloma inguinal also usually painless, and there is lymph node pupones or pseudo pupones happened here. The preterm labor, I think you are all expert now. Speculum examination, pooling, treat. If you have rupture of membrane with pooling, treat. What will be the treatment? What will be the treatment? Tucolysis, failure.
No.
Tucolysis,
Antibiotics
yes.
and
Is contraindicated in rupture of membrane
steroids,
because it
right.
increases the risk of chorioamnitis. So treatment here will be antibiotic and corticosteroid only. When I will give magnesium sulfate?
in imminent, if she is in 4 cm or more,
In
or I
established
will deliver.
preterm labor. Established preterm labor means 4 centimeters, or I will go to deliver her in the morning. She have preeclampsia or she have breech labor or anything, I will do cesarean section in the morning. I will give magnesium sulfate. Magnesium sulfate protocol is only 24 hours unless she have a preeclampsia can be repeated. But in neuroprotection, only 24 hours. Positive pooling, treat. Negative pooling, I will do test. What is the test? Is amniosure or the parts test. Insulin growth insulin growth factor binding protein 1, which is the parts test or the amniosure. Positive treat, negative discharge. And again, for the preterm labor speculum examination, less than 30, dilatation, effacement, so treat. What will be the treatment? Tucolysis here. Corticosteroid, yes. Tucolysis, yes. No antibiotic. Magnesium sulfate, no. After 4 centimeters. 30 transvaginal ultrasound, less than 15 or more, or 15 itself. This is preterm labor diagnosed. More than 15, no preterm labor. No transvaginal ultrasound, I will do the fetal fibronectin, positive and negative. 50 is negative. Positive more than 50. This is the point you argued about it today in the group. The patient have 2 first trimester miscarriage. So I will do ultrasound circulage. Ultrasound circulage. Once I have short cervix, I will do it. Ultrasound indicated circulage. Once I have short cervix between 14 or between 16 to 24, I need only once short cervix to put here in the ultrasound indicated circulage. Otherwise, no.
Sir, I want to ask you how we are doing serial scanning for this preterm labor.
Transvaginal cervical assessment. Transvaginal cervical assessment from the internal hospital. Sorry?
How often? Weekly, 2
2
weekly?
weeks.
How?
2 weeks.
Okay, sir.
In that question, Dr. Hani, it was 2 first trimester miscarriage, not 3.
Yeah, 2 means ultrasound indicated. 3 means elective. Elective means history indicated circulage. If 3 history indicated.
And she was on 14 weeks, not 16.
Yeah, she can be, because they said only once can be done. Just a second, because they said once you have one, sometimes they are saying between 14 and sometimes they are saying between 16. 14, I can do it. You see here? Where is the ultrasound indicated? Here. These women who have a previous preterm labor or a previous prom or a previous circulage or a previous adhesion, these which women with high risk. These women are recommended to be reviewed by a preterm or the preterm dedicated labor or the preterm dedicated clinic by 12 weeks. Why? To do a scan, whichever sooner, with the dating scan or after, and offer here transvaginal cervix screening or scanning in a secondary screening test every 2 to 4 weeks, between 16 to 24. I found her at 12, and I saw her at 14, and she is short cervix, so that's enough. It's high risk already. Woman with intermediate risk, previous CS had fully dilatation or 2 leads, or woman should undergone a single transvaginal ultrasound scan no later between 18 and 21 weeks. Cervical circulage is recommended in any of the group of women considered increased risk of preterm labor. So the question, I will do circulage at 14 weeks. What's the problem? Okay.
So in the question, she is only previous two miscarriage.
Yeah, previous two means I will do ultrasound indicated. Once indicated less than 12, I will do ultrasound indicated. Previous 3, I will do elective circulage before pregnancy or even at 12 weeks. I will not do ultrasound.
Okay, thank you.
I close the file and I will close the recording. That's the end of the official session today.
Sir, in your